So what I'd like to do today is record a narrated three-arm hysterectomy. This is an interesting case. It looked to be pretty simple and it just had a couple things, I think some tips and tricks that I can go through. The thing with the three-arm is you obviously don't have your fourth arm retracting. So a lot of times I will use my scissors as a retractor. You'll see that right here where I pull the tube up and use the back part of the scissors. Don't use the point to kind of retract. So the key to this is really traction counter traction when you're doing a three arm. Um, a lot of times, if the vessels under the meso are not very thick, you'll see this one will bleed a little bit. It's easier if you do the vessel sealer, but what you can do is make a hole and then use the scissors as a retracting device. So we now take the uterovarian ligament up towards the round ligament. I'd already visually identified the ureter. And you'll notice on this case that I really had a hard time getting the bladder flap, and reviewing it, I feel like I was actually not down far enough, so you can take a look at it and see what you think. But once we get through the round, we're going to do the anterior and posterior leap of the broad ligament. And typically what I do is lift up the bladder flap area and try to get into that really spider web material. If you can get the air in that bladder flap, it really shows itself where. This one was a little more difficult. See, there's I think I'm too high, but it does push down. So you'll see this later where I struggle a little bit, which I think is why it's a good video. A lot of times what will happen is if you have a hard time identifying the bladder flap anteriorly, whether there's a lot of adhesions from a C-section, you really want to go posterior, find the cut posteriorly. And once you find the cut posteriorly, you can then circle it around to see exactly where you need to be anteriorly. And the other thing is you can always retrofill the bladder. So I'm looking for the ureter, which is right there. So now I know I can get the uterine variance without any difficulty. Again, I'm looking for that cup, and I'm not 100% sure there. So we're going to start on the other side. One of the techniques, you see how I use the back of that scissor to grasp where I want? So that is a good technique. Just be careful, and you have to be really comfortable about using the back of the scissors. Don't poke anything. But what I was saying before, one of the techniques I use is if you're struggling with a section of the surgery, go to the different spot. Take what it'll give you. The other thing to realize about this case is I have a student manipulating the uterus. His third year medical student has never done it before. So you will see some instances where things are not put as ideally. So it is important to train your vaginal manipulator. That person is really important. So if you notice some positioning issues with the uterus, that's why. I'm trying to use a push spread with the vessel seal, and that actually works pretty well. But again, still having a hard time. So I'm looking down, I can identify the cup there. So I know generally where I need to go. And traction countertraction is really important. Now, what I see there is I see some fat. So typically the fat needs to go away and from the uterus and not towards it. So really trying to make push that away, and I can't quite get it to go away. But this I know is the uterine artery. You really want to get this coagulated really well because once you cut it, it will retract. And then you can lose it. And I feel like I have a little better spot there. I can get that fat down. And sometimes you'll notice what I do with the scissors is use the tips to cut. So it's really power density. So you have a certain amount of energy coming out of the scissors. If you're using one blade, it cuts very well. If you use the back of the scissors and you really have the whole blade in contact, the whole back part of the blade in contact, you're going to get a more coagulatory effect because your energy is spread out over a wider location. So you'll see me use one blade to cut and then maybe the back of it to coagulate. So it's the uterosacral, so we definitely want to coagulate that. They bleed all the time. So there's the one blade cutting. Now I know where the back is, and that makes a huge, now I know where the back of the cup is. I can feel much more confident about where the bladder is. We just have a lot of Nabothian cysts here with some mucus. And this is where you see the student struggle a little bit. Actually, that's not too bad. Now, one of the things I noticed here was the bowel just seems to be pulled up. So what I always like to do is sometimes when I'm taking down the cup or the sidewall is go high and let it fall off. So I'll coagulate this, but then instead of being along the cup, which I am right here, I may go a little higher. See if I do that. It's a little bit higher than I would normally think to go, but what it does is it lets it fall away, so I'm far enough away from it, anything important. And here I'm struggling a little bit and I'm hitting the uterus, and my normal assistant would adjust things for me, but the student just doesn't know how to do that. So we work around it. So trying to get this little bleed. Again, you can see the bladder is not really down sufficiently enough. We need to get that fat away from the cervix. And one of the things I think is actually important in this case is you're going to see I have some bleeding in the right sidewall and vaginal cuff area. And sometimes I think benign gynecologists, we just go in there and just start zapping stuff, and you really have to be careful. So again, this is a student problem, just so you know, he doesn't know how to manipulate it. That's okay. We work with him. But I do want to show you, you get some bleeding in the sidewall, you really can't just go zapping because you don't know where the ureter is. So you really have to be able to find that ureter. We got some scarring here, and I'm just trying to push it down. So again, one blade, and you're painting, and it'll come right down. All right, so now we have the uterus out, and the rest of the case is closing the cuff and then dealing with that bleeding on the right. So camera clean there. So uterus is out, and you can see I have a decent amount of bleeding, and you can see some on the right there. Notice that I have switched my camera angle multiple times, so I highly recommend a 30-degree on every single case. It will save you so much time in the beginning. If you're used to a zero, it will take some time to get used to it, but it is completely worth it as you start doing more complex cases and bigger uteruses. You can peek around the side. So I know I'm medial to the uterine artery there, so I'm not super worried about the ureter in that position. But you can see some bleeding on the right. So that needs to be taken care of. So at this point, I don't know where the bleeding's coming from, and I don't know where the ureter is. I've seen it back here. So waiting for some suction. Now at this point, you have to be comfortable finding the ureter, because if you can't find the ureter, you don't know what you're zapping. You can't just go in there and randomly zap everything. So at this point, I'm looking for the ureter. And if you can't find it, go back up. Go back to the iliac, because that's where you're going to find it. And then you can dissect it down. So we can see the ureter is right there. So I know I'm right on it. A little bit more suction here. And again, this is not the best dissection. That's part of the reason I wanted to do the case and narrate it. Showing you how to do it when it's easy is not that hard. It's when it's difficult that it becomes harder. So there's the ureter right there. I was able to identify it. I knew it was there, so I can zap that little bleeding there. Again, see how I use those scissors as a retractor with the 3-arm? Now again, if I had a 4-arm, it'd be a lot easier. So now that we can see the ureter, we can dissect this down and make sure the ureter's out of the way so we're not having any bleeding. So that space that is medial to the ureter is called the space of Okabayashi. And what you can do is score it with your scissors and then push the ureter away from the sidewall. So right there, you can kind of release that ureter. And then we're pushing it away. The uterine artery is coming in here, which we've already coagulated, which believe I just pointed to. So there's the ureter. We know we're safe. Pushing it away. And then at this point, I know where the ureter is, so I'll feel very comfortable stopping that bleeding. So a lot of people would put to seal, which is fine if you want to use it, but I feel like it's better to just take care of it. So again, I can see the ureter. Make sure it's out of the way. And you can feel safe about coagulating without just random. It really is stubborn. Now, some of this bleeding that's close to the cuff is going to get stopped when you stitch it. And I don't like to char it. I like to leave the cuff a little juicy just for healing, but obviously you can't have heavy bleeding. Still, again, I want you to notice we can see the ureter on the right there completely, so we can be very safe. It is very frustrating, I'll be honest with you. I think this is when I finally get it here. So at this point, we're going to switch, get the needle. You can either put the needle in through the vagina or through the top, doesn't matter. Use a V-lock. I do 9 inches. I think the 6 inches is a little too small. The 12 inches too cumbersome. So I have my needle driver. I don't like the mega cut because I end up cutting my needle, but it's whatever you prefer. So the key with sewing the cuff is making sure your needle driver is 45 degrees and about halfway to 2/3 towards the back of the needle. This needle driver does not have the best grip. So the other key is using your left hand. So I want you to watch my left arm. I'm actually using my left arm to push against the needle as well. So I have the rotational movement of the stitch and I'm pushing the tissue on the needle with the prograsp. I'm actually having a seizure here because the air is leaking out of the vagina, so I do have them fix that. It's sometimes hard to hit a moving target. So poke, turn, poke, turn. So you really need to put the needle in perpendicular to the tissue, get a good purchase, then turn. The other technique you'll see is I can use the needle. See right there, I use the needle to retract and pull up so I can then visualize the cuff. You got to make sure that you get plenty of the vaginal mucosa. That needle is about a centimeter, so don't get fooled by how close you are. So again, I use the needle to retract so I can get a better look. There's not any haptic feedback on the XI, there is on the DV5, but there's almost what I call a visual haptic feedback, and you just have to learn how tighten your stitch. I broke a lot of stitches in the beginning. It doesn't have to be pulled as hard as you think it is. And then once I get to the end, I always put one or two back throws. And then to get the needle out, if you have the suture cut, you could just cut it. I personally just break the needle. You'll see that right here. And then hand it to your assistant. I just did the whole thing.